Thanks, Joanne. And thank you for the invitation to speak today. I'm going to talk about one of our perspective papers authored by myself, Rich Hawkins, Paul Mesmanian, Patrick Romano, who's on our panel today, Herb Smith, who's a colleague at Penn, and Joanne. This is going to be really a 30,000-foot overview of the paper, talking about some of the ground that we've covered. Some of these issues were foreshadowed in some of the discussions earlier today. Jack had mentioned some of them. Robin mentioned some of them, and we build on that initial ANCC document, which has now turned into a paper that's been published that talks about some of the methodological challenges in nurse credentialing research. So, you know, we talked about design and methods issues in nurse credentialing, and we could have gone a lot of different ways, and the strategy that we took was to identify questions and the kinds of things that we were thinking about as researchers, as the things that we need to consider in being able to conduct good, solid research going forward, so that we can understand and address these issues that Jack had mentioned around causality and relationships with outcomes. So the first thing that we considered, and this was really kind of underlying a lot of the challenges, we took a foray into the theoretical world. And because we're researching the credential, the presence of it, its impact, how does a person become credentialed or an organization, we wanted to think about what does a credential represent, and then how does our belief about what we think credentials represent affect the kinds of designs we might undertake. And you know, we have two kind of broad different approaches, and people might categorize them differently, but if you look at human capital theory, it suggests that credentials are not just a signal. They in the process of going through the credentialing journey, something happens. Someone is fundamentally changed in terms of their knowledge or skills. The other, and you know, some might think that it's the polar opposite theory, is signaling theory, but the two do have occasional overlap. Is that the credential is merely a marker of some underlying traits. And well, let me retract the word merely. And I hear Patrick laughing because he made me do it a few times as we were talking about this in developing the paper, because there is value in that. We'll talk about some of the research questions that come in looking at the value in being able to indicate quality and differences in providers that are credentialed versus not credentialed. But one of the implications here is that if we were targeting and wanted to diffuse credentials to those that would be less likely to undertake credentialing, if we believe the signaling theory, then it's not likely that they'll gain anything because they don't have the underlying traits, whether it's additional years of experience or additional education, and that those are the things that the credential is proxying for and being an indicator that then translates into quality outcomes. Each of these perspectives then generates potential questions, a few of which I've outlined here. On the human capital side, we might want to ask, if we invest in and promote credentialing because we believe that it's going to improve quality, what are the results? Does it result in better quality? And to whom do the benefits accrue? If that's our belief about what credentialing represents, we need to then think about the stakeholders and who should be promoting and ultimately financing this, and is it a public good that could benefit a broader community? If we think about credentialing from a signaling theory perspective, we might think about efficiency. Are consumers better able to make decisions about who they want to receive care from based on the credential as a marker of quality? And does it shift any market forces so that employers are differentially hiring, for instance, credentialed versus uncredentialed nurses, or promoting credentialing among the nurses that they have. But as in all things, we don't live in a very black and white world, and it's likely that credentials represent a little bit of both. There's both a representation of some baseline characteristics, but in going through the process, either as an individual for an individual credential or an organization, something changes. There's some fundamental gain in knowledge, skills, changes in the organizational structure or practices or management styles that are also then associated with quality differences. And this tension is one of what we identified as one of the foremost challenges, identifying whether the credential was a marker and proxying for something else, or whether we could promote credentialing and that is essentially an intervention that would result in change. So as has been identified earlier, really one of the things that we keep coming back to is whether there's a causal link. And that could be to any number of outcomes: patient outcomes, nurse outcomes, organizational outcomes, cost for various stakeholders. The issue, and this goes back to our different views about what credentialing represents, is that the kinds of things that we're largely looking at, as opposed to licensure as one type of credentialing, the credentialing that's largely voluntary creates selection issues. Some nurses are more likely to pursue credentialing than others. Some organizations are more likely to pursue credentials than others, and those differences are not random. Our thinking about design is really not about identifying and creating entirely novel ways of gaining a causal understanding, but in looking at the tools that we have to be able to make sense of this scenario where we have selection issues. We have some people who are more likely to undertake the process and some who are not, and being able to disentangle what is the true effect of the credential itself. We talk about some of the tools that we have. Patrick will talk a little bit more about some of these, and we go into detail in the paper, but these are kind of standard approaches for addressing causality. Jack mentioned some of these as well. One that's not on here that he mentioned is the natural experiments. We know these are kind of basic design issues, but being able to apply them in looking at credentialing has been difficult for some of the reasons that we've talked about earlier. Data is problematic. Funding to be able to do a study that has enough data over time, if we want to take a longitudinal approach. These things are the ingredients that are necessary to do good causal research. We have some examples. I point to some of them. There are lots of others. But we're beginning to think about this causal relationship more systematically, and that's the direction that we'll need to go. One of the other questions that we identified and it relates to causality, is getting an understanding of whether we're all studying the same thing. We talked earlier about the dizzying variety of credentials and the lack of standardization for types and categories of credentials. I can talk about my own experience in doing survey research. It seems like everyone who's doing a survey is really identifying these from scratch, and there's no real good standardization. Nancy Dutton talked about the NDNQI approach. Joanne talked about the approach that the National Sample Survey had taken in trying to use some earlier data. But if you look at the lists of nurse credentials, there's hundreds. And really getting a sense of whether you're comparing apples to apples or apples to oranges is important if you want to attribute the effect of that thing to some outcome that you're interested in. So then the questions, that we would generate is which of these variety of credentials matters, or matters more, or matters for particular outcomes. In the instance of organizational credentialing, we'll take the example of magnet hospitals. There are different facets or domains of the magnet hospital concept. It may be that some domains are more important for some things than others. We need to get a better understanding of that if we want to think about credentialing as a way of improving quality. The other issue, and again, kind of moving us toward a better understanding of causality, and Jack talked about this in terms of mechanisms, is getting a sense of those intermediate pathways. How is this, if we find an effect, how is it working? Is it, going back to the signaling theory, is it the fact that, say, individual nurses were better educated or worked in organizations that valued the credential, or is it some additional knowledge and skill that's been gained? One of the other and related questions is the level at which the effect operates. We talked a bit in some of the Q&A about whether it matters more that an individual nurse has a credential, or that there's a critical mass of nurses, or nurses and other healthcare providers, or the team that the nurse is working in is credentialed. At what level does the credential or credentialing process matter? I point out a few examples of papers, and I think that much of the research on individual credentialing has been in the aggregate, and I think to some degree that makes sense to look at, for example, the percentage of nurses that are credentialed. But in part, that's also a matter of convenience, because we are not very good at linking individual nurses with patients. So even if we knew what an individual nurse's credential was, we couldn't link that with any outcomes very effectively. There are some advances in some papers that are beginning to look at that, but up until now, it's been very difficult. One of the other ways of looking at mechanism is looking at it in different contexts. For instance, the Magnet Hospital program is now international, like the Joint Commission accreditation is international. We would want to look in alternative settings, hospitals, nursing homes, ambulatory. Are the same kinds of threads and understandings about intervening variables, are they explaining the outcomes effect that we see in all of these different places, or are there differential effects in different settings? I can give two examples on papers that I'm familiar with that looked, for instance, at magnet hospitals. There's literature showing a magnet hospital effect in both of these papers, one with nurse-reported outcomes, another with patient outcomes, mortality, and failure to rescue. But then they go a step further and look at whether differences in nurse work environment, one of the factors that's thought to be a kind of prime differentiating factor between magnet hospitals and non-magnet hospitals, whether differences in the nurse work environment explain the outcomes effect that we see between magnet and non-magnet hospitals. In both these instances, for those outcomes that were investigated, that was the case. Now we get to not so much design issues, but the design plus. Design can't carry all the weight. We've talked about data thus far. There are lots. I keep a notebook of ideas of studies I'd like to do, but then I also have a column that says, is there data available? And then the next column, which is the next slide, is there funding? Those two columns need to be checked. And I would challenge those in the audience to think about, on the data side, we talked about the level of interoperability. If we want to get to that level 4 interoperability with standardized taxonomies, someone has to pick up that challenge and do it. It's not real sexy, but it's got to be done if we want to do the kind of rigorous research that we've been talking about. There we go. And funding. If data is scarce, funding is even more scarce. You know, and I think that we need to be thinking about alternative funding strategies. What are, you know, there are funders out there that will support the small study, but in order to really develop a program of research, significant funding that can support ongoing studies that build on one another is the direction we need to go. So I see my light blinking. I'll stop there. Thank you, everyone.
Thank you, Matt. And I'd like to remind people, as you have questions come to mind, please write them down, pass them in. Our next speaker is, as was alluded to by Dr. McHugh, is going to be Patrick Romano. Patrick is a professor of medicine and pediatrics and director of the Primary Care Outcomes Research Faculty Development Program at University of California, Davis School of Medicine. He's also a member of the IOM Standing Committee on Credentialing Research in Nursing, and he will be discussing the investigating causal pathways and linkages in credentialing research.